Hello there. I'm a clinical psychotherapist, I'm a sexologist, I'm a mental health professional. I have worked in the field of suicide prevention in sex and gender diverse groups for 50 years. I began a long time ago at Earl's Court in London, Earl's Court Citizens Advice Bureau. And the reality is that our clients can sometimes become suicidal. Lack of care or care we don't want, that's very important. The problem with the medical system and with the care system is sometimes it tells people to do things or be things that is not suitable for the person. And in a 6-minute or a 15-minute consultation, that's not going to work. You have to spend a lot of time observing and talking with your clients rather than talking at them. So when you're dealing with intersex and trans people, you have to understand that their suicidal thoughts can go up to 70%. Attempts can go up to 40 to 50%. And self-harm comes in probably around 30% in certain groups. Because of the pressures, enormous pressures that intersex and trans and sex and gender diverse people experience. The prejudice, the mistreatment, the discrimination, the ostracization at school, in the workplace. It's what I call stacking. It just stacks up those until it gets to a tipping point where people go into trauma crisis and become suicidal. So always screen for suicide potential. Don't assume because you have a happy, chirpy person coming into your consulting room, or if you're a social worker, you're out in the field, that person doesn't have potential for suicide. Always do a mental health assessment, but also do a suicide assessment. A great hurdle in caring for populations is financial restraints and resources restraints. We all face it. We have a limited time with patients, with clients, and we have to be as clear and concise in the work that we do at that time. I understand that in the private sector, we do have more time and more resources. And in government-funded sectors, clinicians can be under great pressure, enormous pressure, because it's a productivity line. So you have to really hone your skills and become very, 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 very astute at spotting suicide and screening for it. When you spot it, you have to do fast follow-ups. Immediate consultation. You can't send someone away for a month or 2 weeks. You have to do intense, fast follow-ups to help people. Cognitive behavioural are often used in institutions, but it is limited because suicide is emotive. It's emotive. So you really need to bring emotional parts in, CBT, but DBT is also useful. If you're in private practice, solution focused. Involve family, friends and help groups. Don't try and manage it all on your own, and also do case histories and case conferences with other clinicians if you need to. Involve parents with children if you suspect or think suicide is imminent, and be very, very careful that you keep 1,000 notes, because note taking enables you, when you come back to a client, that you can go boom in straight away and you're not covering the same ground again. If this is not your area and you're not trained in suicide prevention, then immediately refer on. Take your supervision, because supervision is there to guide us, and that will help you. Don't hang on to a client or a patient because you think you can fix something before the suicidal issue is addressed. That's the first thing that must be addressed. So be vigilant, watch, look, listen, and take care of your patients and clients.